Tachycardic arrhythmias are often classified by the point of entry. Rhythms may be supraventricular, meaning it comes from the atria or from the nodes, or it may be ventricular, originating in the ventricles. Sinus tachycardia occurs when the rhythm is normal in every way, but is over 100 beats per minute. This may be normal in young children or pregnant women. Most commonly, it is a physiologic response to a stimuli or disease state. Etiologies include fever, volume depletion, anemia, or sepsis. Patients may also develop tachycardia during exercise, pain, or after certain medications. Let's discuss some of the atrial rhythms. One of the easiest to recognize is atrial flutter, which is due to atrial depolarization at a rate of 250 to 300 beats per minute. It is most commonly seen in men, especially those with congestive heart failure, low ejection fraction, or mitral regurgitation. This rhythm features a sawtooth pattern, which is the result of hundreds of atrial depolarizations. The ventricles cannot fire that quickly, so they follow a slower rate. Be careful not to mistakenly identify fast atrial flutters as a T wave followed closely by a P wave. It may be difficult to diagnose this rhythm until the heart is slowed by treatment or resolution. Atrial fibrillation stems from multiple places and may be caused by cardiac ischemia, valvular disease, pericarditis, and chronic circulatory conditions like congestive heart failure and high blood pressure. Atrial fibrillation may also be caused by pulmonary issues as well as metabolic stress or drugs and alcohol abuse. In atrial fibrillation, the atria are contracting over 400 times a minute. Since the AV node experiences so many impulses, only a small amount are allowed through, resulting in a slower ventricular rate. This process is irregular. The hallmark sign of atrial fibrillation is an irregular rhythm with no discernible P waves. The atria are quivering, not contracting. Some patients do well with atrial fibrillation at slower rates, though patients with this disorder are more likely to experience blood clots due to incomplete filling and contraction of the atria. Atrial fibrillation may be controlled with beta blockers, calcium channel blockers, or older therapies like digoxin. Patients with atrial fibrillation usually require blood thinners. Supraventricular tachycardia is a diverse group of arrhythmias that may occur via different mechanisms. The most common are atrioventricular nodal reentrant tachycardia or atrioventricular reentry tachycardia. Supraventricular tachycardia, or SVT for short, is usually regular but very fast with narrow QRS complexes. It requires a heart rate over 150 beats per minute. Some adults can handle slower SVTs without compromise, but older adults or patients with compromised health are likely to show signs and symptoms of cardiovascular insufficiency. You should apply oxygen and maintain the airway. Consider getting an IV or IO for drug administration. Stable tachycardic rhythms may just need monitoring, but unstable rhythms need treatment. Assess the patient using the primary survey. If the rate is over 100, look for a narrow complex. If the QRS is narrow, proceed with the narrow complex algorithm. Determine if the patient is stable or unstable. Stable patients may need to be monitored. Stable patients with sustained heart rates will likely need to be treated. Start by performing vagal maneuvers by asking the patient to bear down. If no improvement is noted, consider the administration of 6 milligrams of adenosine and a rapid IV push. The half-life of adenosine is very short, so use a large bore IV located as close to the heart as possible. If 6 milligrams of adenosine is unsuccessful, consider 12 milligrams. If the patient becomes unstable at any point, move to an unstable portion of the algorithm. If both doses are unsuccessful, but the patient remains stable, consider other antiarrhythmic drugs, including amiodarone, sotalol, or procainamide. If the patient becomes unstable at any point, consider performing a synchronized cardioversion. Advanced practitioners may choose electricity levels based on the regularity of the QRS. Regular rhythms may require 50 to 100 joules, while narrow and irregular rhythms often require higher doses. Vagal maneuvers can be successfully performed by adults and may include the Valsalva maneuver or carotid sinus massage. Never perform vagal maneuvers on patients who have irregular atrial rhythms, since these patients may have coronary artery disease or pre-existing clots, which may migrate if disturbed. For more methods and contraindications, please consult your manual. Adenosine is contraindicated in patients who have a second or third degree heart block, sick sinus rhythm, or prolonged QTs. Adenosine is not appropriate in ventricular tachycardia. A synchronized cardioversion is useful in unstable narrow complex adult tachycardias. The patient must have a palpable pulse. Be sure to select the synchronized cardioversion option. Apply the pads to the patient's chest. Switch to synchronized cardioversion mode. Turn the dial or press the button to reach the desired joules. Recall that for cardioversion, a lower amount of joules is used. Press charge and ensure everyone is clear from the patient. Press the shock button. The shock delivered may be delayed by several seconds while the machine ensures the shock is delivered at the right moment in the ECG. For persistent tachycardia, increase the dose of joules and shock again. For narrow, regular complexes, the correct dosage is between 50 and 100 joules. For irregular rhythms, use 120 to 200 joules. Occasionally, patients may have wide complex regular tachycardia. This is also shocked at 100 joules. If the QRS is wide and irregular, you are unlikely to have a pulse. Proceed with immediate defibrillation in the unsynchronized mode. Each machine is a little different, so make sure you know how to effectively use the model you have available. As mentioned before, wide complex tachycardias may require synchronized cardioversion or defibrillation. As always, assess the patient for stability using the ABCD primary assessment. Wide complex tachycardia rhythms are over 100 beats per minute and have a QRS longer than 0.12 seconds, which look wide or bizarre. The T wave slopes in the opposite direction of the R wave. There are no P waves present. The most common wide complex tachycardia arrhythmia is ventricular tachycardia. Ventricular tachycardia may be present with or without a pulse. Younger patients with no underlying health conditions may tolerate short bursts of VTAC, but sustained VTAC needs to be treated urgently. Patients with a pulse may be treated with synchronized cardioversion or medications. Patients without a pulse are treated with immediate defibrillation. Another life-threatening rhythm includes ventricular fibrillation. Just like in atrial fibrillation, the ventricles are quivering instead of producing true contractions. Because the purpose of the ventricles is to push blood throughout the body, VFib is a deadly arrhythmia. In fact, VFib is a common cause of sudden death due to the severe drop in cardiac output. VFib may be classified as either fine or coarse, but the classification has little bearing on the treatment, which is always immediate defibrillation and CPR. A less common version of ventricular fibrillation is torsade de pointe, which means twisting of the points. Torsade also has a wide, bizarre QRS with no association to the P waves, which may be present. Torsade is commonly caused by drugs which produce a prolonged QT interval or electrolyte disturbances. The mnemonic LAM is used to help recall treatments for torsade. These include lidocaine, amiodarone, magnesium, or beta blockers. If the patient is stable and has a regular monomorphic rhythm, obtain IV access and prepare to administer adenosine. If there is no improvement, consider antiarrhythmic drugs such as amiodarone. The first dose of amiodarone in a patient with a pulse is 150 milligrams over 10 minutes. This dose may be repeated. You may also consider sotalol or procainamide, but both these drugs should be avoided in patients with a prolonged QT. If the patient is unstable with an irregular rhythm, prepare to defibrillate. If the rhythm is regular and the patient has a pulse, set up for a synchronized cardioversion. Now you know some frequent causes and reactions to tachycardia rhythms. It is important to determine the type of rhythm so you can intervene with the correct treatment. You can find more information about the drugs and electricity doses used for these patients in your manual.